welcome, ladies and gentlemen. I'm Péter Misnyovszki, and on my PhD, I'm working on clarifying violent death through the assessment of diagnostic methods and the identification of several risk factors. As you can see, my topic is a little bit different, as I work as a forensic medicine resident, and my vision is that in the near future, Vertopsy will be included in all postmortem evaluation procedures. To get to our goal, we are working on two different topics, one of which is on the postmortem Vertopsy techniques, and the other is on a possible association between weather parameters and the incidence of suicidal death cases. So our first topic is on the Vertopsy techniques, and the title is Uncertainty of the Certain Autopsy Alone Does Not Meet the Requirements of the Modern Postmortem Evaluation. And we are working on writing the article, and we are willing to send it into the Journal of Criminology or Investigative Radiology. So I can even hear the questions in your head, but Peter, what is this Vertopsy you are always talking about? So these Vertopsy techniques are radiological techniques which can let you find lesions, which can be also found in autopsy cases, but through without having the autopsy itself, through having a PMCT, a postmortem computed tomography with or without angiography, or a postmortem magnetic resonance imaging carried out. So once again a question, but why is this important, and can this be even used? The importance is highlighted by that there is an average of 25.6% autopsy rate in the EU only. That means that more than 1 million cases are carried out every year in the European Union. And while this is still present, there is a clear public demand to reduce these numbers and to reduce the number of traditional autopsy cases. And to do that, these Vertopsy techniques, the postmortem computed tomography and magnetic resonance imaging, can be used. These are a possible replacement for autopsy. Okay, so to prove that, we pose the question that can postmortem imaging techniques replace autopsy? And to prove that, we had the hypothesis that the diagnostic parameters of these techniques reach the supposed golden standard of autopsy. And we are doing that through meta-analysis and a systematic review. Thus, we had a systematic research done, and we are left with 102 full text of which we did the data extraction. And during the data extraction, we found that autopsy is not really behaving like a true golden standard. There are discrepancies which we couldn't properly explain, and thus we used a statistical analysis. It's called Metatron. It's a package for R language. And it says whether reference is a golden standard or not through the p-value. And if it's not, then it can help you correct the values you get. And we've been left with the p-value which is lower than 0.05, meaning that autopsy is not behaving as a golden standard. And here you can see one of our tables from the original and the corrected values from skeletal injuries, and you can see that there is a huge difference. However, these corrected values can be a little bit overshoot, so further assessment of the values will be carried out. However, you can see that there is a clear difference. And you can ask that, yes, you only compared it to autopsy, so there are other things like histology and toxicology. Wouldn't that help to find these differences? Once again, these were carried out on skeletal injuries, right? So toxicology and histology wouldn't help with that. Okay, So how would these techniques help us? So we still have to prove that as a supportive method or as a replacement method, they work. So we have a CT examination, we get some results, and we have to decide whether we accept the results or just discard them. If we have a very high sensitivity and specificity, we can accept all the results. But unfortunately, that is not the case in most of our subgroups. So we have to go back and we have to check whether the results are positive or negative, and then we have to decide whether we can accept a positive result or negative. That can be done through the positive and negative predictive values. The problem with that is that they were not used as the primary diagnostic factors because they show very high relevance or a connection, close connection to prevalence, right? So the higher the prevalence, the higher the PPV and the lower the NPV. And in Li Fang et al. Made this article in which says that there was no systematic difference between the goodness of fit of predictive values and on sensitivity and specificity, so it most likely can be used as such. You can see this is just to show you the connection between the prevalence. The prevalence is low on top and higher in the lower parts, and you can see that the PPV is getting closer to the slash line, and the NPV is also getting closer, so it's losing its value, so it still behaves like that. Okay, so going on to the results. We have very high MPVs in neurological, respiratory, skeletal injuries, and somewhat high in soft tissue injuries. So in these cases, PMCT can be used as a way to exclude these injuries. So if you got a negative result, then we can exclude them. I will get back to cardiovascular cases later because we don't really should rely on just normal PMCT. But on PMCT-A, which is with angiography, and you can see that there the sensitivity and specificity are both very high, and even the positive predictive value and negative predictive values are 0.96. So this is something which, if we are looking for cardiovascular injuries, something which could replace as a whole for this type of lesion. Some PMMR results. Once again, PMMR is most likely to be used as an to exclude some kind of lesions. As you can see, the NPVs are quite high. As a summary, I can say that autopsy alone is not sufficient, and that in some cases the Vertopsy techniques can be used as a replacement, and in most cases they can be used at least to exclude several kinds of lesions, the presence of several kinds of lesions. And unfortunately, there's a high heterogeneity between the articles. Thus, we have to get some kind of proper report technique to be assessed. The strengths are that this is one of the most up-to-date and comprehensive evaluation on the matter. We have the highest number of articles, and we used a very investigative statistical approach. As I said, the imperfect golden standard and the high heterogeneity are the weaknesses of our study. My second topic is forecasting by weather, which is going to be a registry analysis. Some thoughts on his background is that even in Hungary, there are 4.25 suicides every day. So the suicide rate is very high. There are some publications available of a possible association between weather parameters and suicide cases. And we are aiming on to summarize these parameters and check whether any parameters affect the suicide rates in our registry. The population is the population of the mentioned counties, because those are the cases that get into our institute, and we have the registry on that. The exposure is a significant change in meteorological factors, and the outcome is unfortunately the increasing the suicidal rates. And our clinical question, does this meteorological data show association? And we can use it by providing a better use of the available funds. Unfortunately, psychiatric wards are understaffed and underfunded, and we can help with that if we find an association. Registry has 17,000 suicidal cases, and we have all the relevant variables available. These are my specific goals, and I found a quote: physical evidence cannot be intimidated, it does not forget, it doesn't get excited at the moment something is happening like people do. It sits there and wants to be detected, preserved, evaluated, and explained. Thank you for your patience.
My question is regarding your second topic. If I have seen it well, previous studies showed association between the hot weather and the amount of daily sunlight. So as an outsider, I would think the opposite. Do you know what is the reason for that?
These are just some picked articles. There are articles on the opposite too, unfortunately. So that's why we are doing this registry analysis, because the connection is not clear in any of these cases. And there can be various examples for basically if the weather is sunny, people go more outside. And sometimes it's not that they commit the suicide at that time, but they are found at that time, right? So it could mask the results, but with careful statistical evaluation, you can solve that also.
Congratulations on your presentation. I'm nowhere near an expert in this field, so I would like to ask that who actually does these autopsies?
Autopsies?
Yes. So are the radiologists doing these, and do the forensic pathologists are involved, and how much they are involved in this, and the diagnostic part of this? And is there already like a subspecialty for forensic radiology?
Yes. So I came back to a proper golden standard. So what I saw is that first, forensic autopsies are carried out by forensic experts. Then pathologists can do other type of autopsies and so on, and radiologists do the assessment of radiological images. There are joint trainings for either side for forensic radiology training, but unfortunately this is not regulated yet. And what happens is that they are, in most cases, they are blinded to the other, and in the end, they have some kind of result, which is usually from the autopsy. Which should happen, in my opinion, as a golden standard, is that they are doing an autopsy and doing the recordings when they are both blinded. Then they get each other's results, and they can continue their evaluation. So first we have a report from the autopsy. We don't stop the autopsy there. Afterwards we look at the results. Then we continue the autopsy. Then we finish the autopsy. First the radiologist look at the results, then gets the autopsy results, check the results, and they have a joint expert opinion on that. And then you can see which are the real results and which are the false positive, false negative, and so on.